We're broadcasting and recording.
Alrighty, welcome. We just opened up today's webinar, or our second webinar of the day, and people are starting to stream into the webinar here. So as you can see, there's a PowerPoint presentation that's going through right now, and we just want to welcome you all to the Washington Academy of General Dentistry Stay Home, Stay Healthy CE series. This CE series is being brought to you by the School of Dentistry, University of Washington CE Department, and various other sponsors, including Comet USA, Patterson, the University of Washington Academy of General Dentistry Student Chapter. We have our friends at Seattle King County Dental Society, Pierce County Dental Society, Snohomish County Dental Society, and the Canadian Academy of Restorative Dentistry and Prosthodontics. We want to welcome all those that are new to our webinar series from California AGD, Texas AGD. I understand we may have some people on from Nebraska AGD, Arkansas AGD. Hey, look forward. We're going to be doing an Arkansas AGD day in about a week and a half. So our good friends in Arkansas, Dr. Ross is putting together a lineup of 3 top-notch speakers, as is the Canadian Academy of Restorative Dentistry and Prosthodontics. We've already got those 3 speakers lined up for a Card P day, and so looking forward to that. Also, the International Academy of Nathology is going to be presenting 3 webinars for us, again, in about a week and a half. For those of you that have CE questions, today you'll be issued CE based on the number of hours and time we spend in this study club today. So it may vary from an hour and a half to 2 hours of continuing education. Those CE credits will show up on your email inbox in the next day or so. They'll be in PDF format, and they will be coming from the University of Washington School of Dentistry CE department. So if you get anything from UW, it's not spam, please take a look at it. Remember, all this CE is coming to you free of charge, and this is all donated time from our speakers. So Dr. Yassin has donated his time, Dr. Rasner, you name it. Every single person that's presenting here is not taking an honorarium. So thank you for helping us put that together. These are all good friends of the Academy of General Dentistry, and we look forward to having them in presentations, including our master track down the road. For more information about upcoming webinars, you can either use the QR codes that are flipping through here, or you can go to WashingtonAGD.org. So there'll be a list of the free webinars there, but there's also some other courses listed as well that are pay-per-view CE courses that we had on the docket long before, and it's really not fair to ask those presenters now to give away their time. So for AGD members, we will be reporting your CE credits directly to the Academy of General Dentistry. Those AGD credits should show up in the next couple of weeks, so don't be looking for it just because you get the PDF certificate from the University of Washington. That does not necessarily mean that it's going to show up on your AGD transcript right away. Got lots and lots of great webinars coming up. So please take a look on tomorrow. No, pardon me, Wednesday afternoon. Michael Giardino. He is going to do a update, a review of the new perio classification system. And I know it's frustrating every time we turn around, those darn periodontists are doing some kind of new classification system. But for those of you that need to bring your hygienist, your front desk, and yourselves up to speed on that, please attend that. Again, that's free. That's from one of our graduate residents at the University of Washington School of Dentistry, considered by some to be the greatest dental school in North America. Anyways, moving forward, we're just about on the hour, so I'd like to thank all our sponsors: the Washington Academy of General Dentistry, the University of Washington School of Dentistry CE Department, Comet USA, Patterson USA, Seattle King County Dental Society, Pierce County Dental Society, Snohomish County Dental Society, the Canadian Academy of Restorative Dentistry and Prosthodontics. We'd also like to thank the Croatian Academy of Aesthetic Dental Medicine for promoting us. We appreciate it. And we look forward to the second part of Dr. Yassin's Implant Study Club. This is basic surgical and extraction skills with an emphasis on implants. So it looks like we're right on the hour here. If you have any desire to see any of these webinars that you've missed or share with your team members, you can go to YouTube and look up Washington Academy of General Dentistry, and be sure to subscribe and like our page, and we will try and notify you anytime a new video is up. The video of this presentation should be on YouTube within the next half day or so, but be a little bit patient. If you've seen a flyer of somebody that's listed here and it's not on our AGD registration site, give it a day or so too. We're constantly updating that. And everybody that's doing this is volunteer. We'd like to say thank you to our Executive Director, Valerie Bartoli, and we'd like to thank our panelist, Dr. Gary Hayamoto, who's sitting in on all of these sessions. Today, if you could do us a favor, if you have a question, do not put it in the chat feature. Use the Q&A feature. I see we already have somebody with a Q&A question here. I'm going to open this up and see what it looks like. Terrific. All right, we'll get to that question later. All righty, I think that covers everything. So without further ado, I'd like to welcome Dr. Alan Yassin and his special guest today, Dr. Steve Rasner. With that, I'm going to stop sharing my screen, Dr. Yassin, and you have the helm.
Perfect. So I think here we go. Thank you so much, Dr. Hess, for this introduction. I know it's a full-time work for you guys. The Washington Academy of General Dentistry is doing a great job covering this program, and great speakers, a lot of interesting talks. So thank you so much. I know it's a lot of work. Welcome everybody to my study club, Implant Study Club. This is the second session of the Implant Study Club. We started last week. And we still have 3 more sessions coming on Wednesday, April the 29th, Friday, May the 8th, and Wednesday, May the 13th. This study club is a weekly meeting, online meeting that we designed to be really a practical, interactive session where we gather with our not only dentist students, but also from all over the nation, the globe also. A lot of doctors, they are joining us with a lot of questions and answers. I'm hosting a guest every time in this Implant Study Club, trying to focus more on clinical stuff, daily implant dentistry, great guests, great speakers, We are trying to do all the stuff from Seattle here in Washington State, the city of Goodwill. It's amazing that we've been through this outbreak, the COVID-19, and I'm so thankful that in Washington we are in a good shape. At least we are flattening the curve, starting to go down, and I hope everybody else are staying safe out there and just follow our steps. Today, we're going to be talking in part 2 about some basic surgical and extraction skills. I have a very special guest. Let me welcome Dr. Steve Rasner to this session. Welcome, Dr. Rasner. Thank you for joining us today.
Thank you, Alan. It's an honor to do anything associated with Seattle AGD and Washington Dental School and yourself.
Thank you so much. It's an honor to have you. Dr. Rasner is, you know, he's well known for in the field. So I just would love to introduce you in a couple of words. I know you've been doing a lot to the field, so thank you so much. Dr. Rasner received his dental degree from the University of Pennsylvania, and he did a lot of continuing education, including the mastership from the Academy of General Dentistry. And I do believe that you did some implant training with several institutions like MISH or PICUS institution. This is why you see most of his talks and practice mainly focusing on oral surgeries, dental implants, and I was you know, I met him a couple of times. Dr. Rasner, he always come to Seattle here with the Washington Academy of General Dentistry, doing some of his teaching and lectures from the atraumatic extraction and the other, you know, recently you had this online podcast, right? So I'm pretty much, I'm enjoying it every time I see it. Is it like weekly, or like are you trying to do it bi-weekly?
Yeah, no, my podcast, Doc, is called the Lion-Hearted Dentist Podcast. I've done it for about a year and a half. It's weekly. And what I mean by that, I want your listeners to know, what I mean by lion-hearted is the dentists that want to still fulfill their dream that they once owned, you know, in dental school. Like everybody was never thinking back then, oh, I want to become a dentist and work for a giant corporate chain. Not that they're all bad, but I think the dream was to have your own practice, your own philosophy, your own little community. And that's what the lion-hearted dentist is about. It's about not giving in to all the things that are difficult for us today, from toxic insurance. You know, it's based on my fee-for-service practice in a very difficult place to do this in Southern New Jersey, because I'm surrounded by lots of stuff that you guys are surrounded by. I'm surrounded by a very downtrodden economic climate. That's where I'm from, by the way. So that's where I went back to practice. And unfortunately for me, it never became a great place for people to want to flock to. But despite that, I think I have proved to many of the guys and female doctors listening that you can have the dream, even in a place like my place is. And that dream is practicing comprehensive dentistry on your own terms. It's having a fee-for-service practice, not 100%, but primarily, very high degree. And most of all, doing skills that you acquire from everything from webinars like this to the courses all around the industry that allow you just amazingly diverse days. You have to know that I never dreamed that, and I didn't graduate dental school and mistake myself for the #1 student in the class, because I wasn't, you know. But with our amazing continuing education, you can unbelievably carve out really high skill sets in arenas that you're interested in. We're talking about oral surgery skills, which I find fascinating. I always did. You could do it in endodontics. You can do it in a lot of things. But when I get to my part of this, I'll be very clear about the meat and potatoes. I believe that will help a lot of listeners today with the most basic extractions as they prepare those extraction sites for implants. So,
Perfect. Thank you so much. Looking forward to it. So today, as Dr. Rasner said, we're going to be focusing on some basic skills in implant dentistry. Our session is an interactive session. So please, doctors, if you have any questions, go ahead and ask the question. We have Dr. Hayamoto, myself, or Dr. Rasner. We will be guiding the discussion. So mainly all the questions should be answered. If you feel you need to, you want to share some of the cases with us, please contact Valerie or Dr. Hayamoto on the chat so we can give you a chance to share your screen and we can get more towards a clinical discussion as well. I'm going to start the whole thing today with a little bit of an introduction from my end, and then Dr. Rasner will take over and will give us some of his tips and tricks in extraction and in implant dentistry in general. Um, you know, I'm based in Seattle. I'm Alan Yassin. I'm dual trained in both perio and oral surgery. I'm a graduated perio from the University of Washington, and I'm a clinical affiliate instructor there. I am honored to be the course director of the Washington Academy of General Dentistry Dental Implantology program. We have a full 1-year program that it's really heavily clinical and live surgery and hands-on program that we are proud actually to have here in Seattle. I'm going to start the whole discussion about extraction, talking about this word, the art of dental extraction. I had this discussion with one of my friends when I was in the dental school learning, doing extractions. And mainly I learned this word because every single case is different. Every single patient is different. So doing the extraction is um, as more extraction I do in my life, and I've been practicing dentistry, oral surgery mainly for almost 20 years, the more that I do, the more that I know that there is no easy extraction. Every single extraction is unique by itself. And I know that I'm confident with my skills. I received enough training with this. I know that I've never said in my whole life that this is an easy extraction, should take a couple of minutes or should take 5 minutes. You never know. You need to plan right for your cases, for your extractions. About terminology, the main thing always we said when we do the extraction, we start taking out teeth for any reason. We say we need to do it atraumatic extraction, and this is the way that we are trying to mention that we need to save as much as we can from both hard and soft tissue. Extraction itself is a trauma, so we are trying to preserve as much as we can, do it as gentle as we can. For me, I refer to the atraumatic extraction, and the term I call it preserving safe extraction, PSE, which will summarize the goal of the gentle, minimally traumatic extraction that we say. Dr. Rasner has beautiful course that I attended myself about atraumatic extraction, a full day course with hands-on. I recommend to take a look at it, and then we will learn from him and this lecture as well. I would love to summarize my, I call it the 4 wonders for successful surgeries. It's mainly 4 steps to master your surgical approach and skills. One is to learn. The knowledge is the key, right? Whenever you want to do surgeries, you need to know more about the anatomy, more about the literature, and know exactly the techniques. Learn why and how and when to do surgeries. And the second thing is to practice doing skills. Know that the first time you're doing any procedure is going to be different than your hundredth time. It's going to be different than the thousandth time. Every single experience will give us more self-confidence and better understanding for our shortcomings. The third thing is the investment. We need to make sure that we are investing as much as we can in our dental practice, in our surgical practice, in our communicating with our patients. Our main goal is just to provide the best service to our patients. This is the goal, and then grow ourselves as a clinicians. So investment will get back to you when you get new instruments, new machines, high-end technologies will just pay you back. And finally is to see when you do surgeries, you need to make sure that you have a good vision for what you're doing. You can't really just try to do surgeries under a lot of bleeding. This is why do whatever you can do to make the best surgery, extraction, implants, small surgery, minor surgery, major surgery, whatever surgeries you're doing. The best thing to see is to have good vision, good flap design, good reflection, good bleeding control. And from these 4 points forward, you can proceed with whatever you want to do in surgeries. I know we have different levels from our participants. Some of them, they have fresh graduate dentists. Some of them, they are advanced. I have a couple of my specialist friends already attending, but I wanted to cover some of the basics and our extraction, opening to Dr. Rasner, so we can proceed with better understanding for what the extraction leading to dental implants would look like. When we have an extraction, the healing steps would be with first getting our blood clot. This is where we want to try to stabilize the blood clot to get more into better healing. In 2-3 days, we'll proceed with some granulation tissue below the blood clot, starting from the very deep inside the socket, going all the way from for 4 to 7 days. We will start to get more granulation tissue. In 1 week, we will end up with some increased connective tissue and osteoid and some of the epithelium getting into the coverage of the socket. And in 3 weeks, we'll get more connective tissue mineralization, and then we'll see more of the epithelium getting into the 6 weeks, all the way until after the extraction socket in 8 weeks will be some active osteoclastic activity into the bone formation. Remodeling of the bone will start in around 8 to 12 weeks, where we can get more reshape of the alveolar bone. So the extraction socket usually will go through a lot of steps for us to get into the regular ridge into it. And I know Dr. Rasner has great presentation for to understand exactly why we are preserving the ridge, why we are doing this bone or socket grafting in general. The why we graft for implants, why we try to link this extraction with an implant, it's you know, in the literature it was described enough that we have this remodeling or the bone resorption, ridge resorption, alveolar bone resorption going after the extraction. So when we place our implant, we try to surround our implant at least with 2 millimeter surrounding the implant to support the titanium and the threads and give us a good emergence profile for our restoration. The study for mesh, for example, in 1990s, they showed that we have 40 to 60% of the width of the ridge will start to resorb in the first year after the extraction. So we know for sure that we're losing bone the moment that we lose our teeth in the ridge. The main thing that we had this discussion last time and our part one is when we put the implant, it's gone the days when we are talking only about osseointegration and the implant to integrate with the bone. We need to place our implant thinking about the restoratively driven implant dentistry. We need to know where is our final crown to be placed. And this is why we need to make sure that we have the platform of the implant placed at the perfect position, ideal position to get the perfect emergence profile and the restoration over the implant. If we have bone resorption, sometimes we need to fulfill this engagement between the implant and the bone. So a lot of times, especially in the anterior area, you see the doctors with less experience placing the implant with more inclination towards the buccal, which will make it a little bit harder on the soft tissue and the hard tissue to accommodate this placement. Again, if we are trying to follow whatever bone available, sometimes the implant will engage with the buccal plate where we're gonna get more bone resorption and more titanium to show in place. So this is a just quick introduction. I know that we will be able to discuss this in details. Dr. Rasner, this is the slide that I worked on just to show that, you know, in our extraction, the beginning of the implant story, right? Either by extraction or missing teeth, we have we are lucky to be providing services to patients. Our patients trust us, right? And you have a unique and amazing understanding for this relationship between the doctor and the patient. So this is the slide that I want to stop for a minute and give you some time to comment on. Losing a tooth, where should we go? Immediate implant, bone grafting, do nothing. Considering the services that we are, the responsibility for us to provide our patients with a great service.
Yeah, well, you're asking me to comment on this now, Doc?
Yeah.
Yeah. Well, you know, every clinician has his own style. Like, you know, there's obviously a great emphasis on immediate replacement of the lost tooth with an implant. I've always been, and you know, you're influenced, as you know, by your mentors. And so it's important that you know my mentors were Carl Misch and Mike Picos, probably the most out of all the people that I've trained with. But I'm kind of an old school guy, meaning that I don't mind grafting and waiting to optimize the time when I put an implant in, you know. Now, those listening have to understand that there's such a wide range of opinions on what you and the possibilities of what you can do. But I don't think you would ever go wrong by optimizing a site and reducing the possible risk of not less than optimal outcomes of what you're trying, particularly in the aesthetic zone. You know, so, you know, if I had to sum up for me, unless it's abundant bone, especially, of course, on the buccal, unless it had a thick biotype, you know, I tend to be a guy that says, well, what will 12 weeks in the life of this patient really mean? Meaning the 12 weeks that we have to wait, or the 16 weeks to get an optimal outcome. You know, I don't think we would ever regret that. And I have to say that I think the operator, the clinician, influences his practice by those thoughts. Like, my patients don't think that's a big deal because that's how I think. So I'm always ready to offer a provisional. And I understand they're going to be in a provisional 3 or 4 more months than they would have been. But I seem to think it's okay. So my patients, like your patients, they believe in your philosophy. That's why they come to you. So I generally err on the side of being a little conservative, hence waiting when I can, except for the small parameters I just gave you, Alan.
Yes, yeah. Well, thank you so much. This is exactly, we're on the same page. It's mainly it's different from case to case, and you are in charge to make the right decision. I just wanted to pick your brain in this thing, because I'm going to be discussing and a lot of small stuff of classification before doing the extraction. For our understanding for the implant cases, when we have two different concepts. We have the tooth position inside the alveolar bone, and we have the socket after the extraction. If you can see, not every single case would be a good case for an immediate implant, because a lot of time we don't have enough bone available for implant placement, or we lost the bone available after the extraction. So in our minimally traumatic extraction, preserving safe extraction that we are practicing, our goal is at least to preserve what we have before doing the extraction with this tooth inside the alveolar bone into after the extraction, which we call it the socket after the extraction classification. Let me explain a little bit more. This will mainly be diagnosed with a good sagittal three-dimensional CT scan to provide us with more information what bone is available around the root, around the apex. Do we have any fractures? I always say, when we are thinking about providing immediate implants or atraumatic, minimum traumatic extraction, it's important for us to have more information and get more of three-dimensional CT scan, mainly to know exactly where is what is the position of the root in the alveolar bone before the extraction. We have a lot of classifications from this side. I like to use the classification came in 2011 and modified in 2012 by Can and colleagues from the Loma Linda in California. They classified the teeth, especially in the anterior area, for type 1, where the tooth will be more engaged with the buccal plate. And this type of cases, when we do the extraction, we still have the risk of fracturing the buccal plate, but we'll still have some access for engaging an implant and an immediate placement at the palatal aspect. The type 2 of the root positioning inside the alveolar ridge will be in the middle of the ridge. We still have enough bone here on the palatal side to engage the implant, while we have a little bit thicker of the buccal side on the buccal plate to support. Class 3 and class 4, they are pretty much not a good case to engage immediate implant, because we don't have enough bone to engage it at the palatal side, or if the tooth of the class 4, where it is in the middle of the positioned in the middle of the alveolar ridge, which will make it a little bit harder for us to place the implant inside it. So this classification will help us understanding when we do the extraction, we are trying to keep it as is. We don't really try to lose more bone, because there's another classification, we call it the classification of the extraction socket. Our goal is to keep whatever we have classification before the extraction to the same available bone and soft tissue after the extraction. Also, there is a lot of too many classifications for extraction sockets. I try to use this simple, straightforward Salama Brothers, and also give it in the late 1990s, when we have, after the extraction type 1, we have the buccal bone, the palatal bone, and the soft tissue available, while in the type 2 of the bone, we'll have loss on the buccal plate, but we still have some soft tissue. This case will be a little bit challenging for immediate implant placement, especially in the aesthetic zone. While in the class 3, when we are doing the extraction, losing more soft tissue and bone at the buccal side, which will make it really hard for us to consider any immediate implant or immediate provisionalization. So this is the main concept for our extraction. We need to try to preserve as much as we can from the soft tissue and the hard tissue to keep the site exactly before the extraction into the same after the extraction, utilizing and using as much as we can from the hard and the soft tissue into the area. So as I started the whole discussion, there's no easy extraction. Every single extraction need to be really studied carefully. The principles for any extraction should be a proper clinical evaluation of teeth before removal. See exactly if we have any access for the tooth, what's the mobility, what's the condition of the crown, what's the condition of the adjacent teeth. Radiographic evaluation, especially if we are getting into immediate implant placement, we have to have some kind of CBCT, three-dimensional CT scan relationship to the vital structures. What's the root configurations, condition of the surrounding bone. And of course, as long as we are advancing our surgical skills and instruments, there should be, we should be in a good situation to do the extraction. One of the slides that I like always to spend some time to, I know most of you, they know these concepts, but I always like to remind myself and others about it. There's two different types of evaluation for the extraction. One is the safetiness of extraction. Is it risky? Do we have any relationship to any vital structures? The second thing is the complexity. So there's two different concepts that we need to make sure we understand it. And I always like to give this small example. My front desk ladies, my assistants, usually I share my knowledge, try to discuss with them so they know a lot about doing extraction and dentistry in general. Sometimes they put a case and they will tell me, hey, Dr. Yassin, this is an easy extraction. We just sneaked this surgery for only 20 minutes. It's straightforward, 16 years old, Caucasian lady, erupted tooth, and it's gonna take you 5 minutes to take it out. And then when I take a look at the X-ray, I see the tooth is erupted, probably lower molar, but we have long roots, we have a great curvature, we have a proximity to the IAN. Mainly the tooth is, the extraction is not complex, it's not easy, it's complex. So it does not matter that it is the tooth is the patient is young, or the tooth is erupted, or the tooth is the crown is there. That does not mean that the extraction is straightforward and easy. So for the safety measures, I like to consider looking into the relationship with the IAN maxillary sinus, the two most important vital structures we deal with, proximity to the adjacent teeth, the bone density, general health and conditions. On the complexity side, to see exactly what is the tooth condition. Root canal treated teeth, they are a little bit more complicated than vital teeth. The tooth location, mandibular teeth or posterior mandible, is way more complex than the maxillary teeth. Tooth positioning, is it erupted, impacted, horizontally impacted, root length and curvature, age of the patient, ethnicity of the patient is really important to know, future treatment plan, and one of the most important things we need to evaluate is the patient anxiety level and see exactly if we need to consider sedation, oral sedation, IV sedation if you are able. I know Dr. Rasner has an opinion about sedation also. I would love to get his opinion about it. So to just make it really quick, I I know Dr. Rasner will talk about it in details. I want to mention several small tips and tricks for extraction. Periotome is really important for any less traumatic extraction, or the way that we're gonna go with removing the teeth and considering immediate implant placement. The periotomes should be from a good strong instrument that is not. I use the black line instruments and as a periotome. The main goal for a periotome is to go between the tooth and the bone and the PDL space and just open it for us to get a little bit better mobility with the tooth to be removed. The movement of the tooth of the periotome should be parallel to the surface of the tooth. So we're trying just to enter this periotome and the PDL space and trying to open more of the space to get better movement, mobility for the tooth before applying our forceps to do the extraction or before applying our elevators to do a better extraction of the tooth. So the periotome and considering the correct instrument to mainly to get the tooth out, the forceps is very important. And as I'm gonna be explaining here, I have a lineup of some instruments that I love to use. The forceps, they are, you know, we have a lot of forceps. I use the European style forceps, which will make it a little bit more it's a big difference than the regular forceps we use. One, it's serrated at the end. Two, it is studied to be covering the surface of the tooth, either by the crown or even the shape of the roots underneath it. So I use the 79 for the mandibular thirds, for example, the 46 for the mandibular roots, 67 the maxillary third molars, and all of them, they are the European style that will give us better friction between the forceps and the tooth underneath it. Number 13 for the premolar, number 51 for the roots, for the upper maxillary roots, premolar here number 7 for the maxillary, and the 73 for the molars. If you don't really, if doctors, they don't have any experience with those kind of forceps, you will try them and you will feel there's a big difference between the friction catching the teeth and the crowns and even the crowns underneath it. Choosing your elevators, I know we have a lot of doctors using 3 different sizes of elevators to do the extraction. One of the tips that I always want to share with doctors is think about thin blade elevators. This is what matters, because our goal is just to get less trauma to the bone, trying to apply more on to expand the PDL space and get the tooth out without really any pressure around the tooth. So a small thin blade of elevators, this will make a big difference for us. And finally, when we're talking about surgery, and I first talked about vision and seeing exactly what's going on, personally, I do surgery always under retraction like this. I use this nice plastic retractor and bite block for patients to feel safe and controlled, and at least you will see exactly what you're doing under the surgery style. And one of the most important thing, you're freeing your another hand for your assistant from doing the retraction, and you will get better support for your surgeries. Dr. Rasner told me that he's going to cover some of the bone graft whenever we are dealing with immediate implant socket preservation. Just touch base really quick with options for doing the bone graft, autograft from the patient, allograft from the human or donor bone, xenograft coming from other species, from animals, mainly bovine or porcine, and alloplastic materials to do some synthetic bone. Uh, all the bone graft materials will give us one of 3 mechanics to build bone: osteoconduction, all the bone grafts, autogenous, allograft, xenograft, or the synthetic bone will give us like a structure to build the bone. Your body will use this net to build your own body. The osteoinduction osteoinduction would be more of induction for the recipient side to create more of the bone. We see it at the autogenous and the allograft, the demineralized allograft. And osteogenesis, where the bone graft itself will grow more bone, will get only from autogenous bone graft. So it's not a bone graft class. I just wanted to touch base. When we do the bone graft, we have several membrane materials, either resorbable, non-resorbable, synthetic, or non-synthetic. Probably most of the cases we can deal with collagen membrane, the resorbable collagen membrane. We have another type of synthetic polymers like the PLA or PGA, EPTFE or PTFE, the non-resorbable membrane, which will require us to be removed after several times of healing, and the allogenic, the placenta products, is really a good new advance in our surgeries. So I wanted just to get into a small introduction with extraction and brainstorming to open the time for Dr. Rasner to share his knowledge about the extraction and surgical skills. We are on the same page, me and him. We had several conversations. So Dr. Rasner, I just want to finish with this case. Simple, straightforward extraction of the posterior area. Obviously, it's root canal treated. It's mainly, it's not a straightforward extraction. Whenever we have long roots, we have root canal treatment for a long time. Obviously, the tooth has a huge restoration. We have some resorption going on underneath it. So the extraction needs to be, sectioned and taking the tooth in pieces after the extraction, putting the bone graft using FDBA bone graft, covering the whole area with PTFE membrane. It is non-resorbable membrane that needs to be removed in 3 weeks. And then after 3 months or so, considering that we had a class 2 extraction socket, losing only 2 millimeter of the bone on the buccal, placing an implant, and the place, as you can see, we have solid bone, nice attached gingiva, keratinized tissue surrounding it, restoratively driven placement with a good enough space for our emergence profile, and then putting the implant with one stage placement with a healing abutment over it. So this will just open the whole discussion for us to see, is this really a complex or easy extraction? Could we do immediate implant placement even in the posterior or not, posterior area or not? I want to leave those kind of small discussions to Dr. Rasner. I'm going to stop right now my screen, and you can start sharing your screen, Dr. Rasner, and
okay. Can you guys see me?
yes.
A second. See me now? Is that good? Can I see the slide screen? Okay.
Yes.
Well, first, let me compliment you on a tremendous presentation. We should go on the road together because we believe in many of the same things. And
Absolutely. I agree.
It's really, so the very first thing I want to say to those guys listening is I would assume that there's many, many GPs listening right now. And I want you to think about what just happened. Think about it. I'm a guest on a program hosted by an oral surgeon and a periodontist. And how fortunate we GPs are in 2020. And I know this is about, and believe me, I really spent some time to get into meat and potatoes for you, which I'm going to get right into. I tried to cut out all the fluffy stuff, but it's impossible for me to proceed without saying this, because when I started in 1980, what would happen is you would see specialists show their work so that you would send everything to them to do the interesting things. And we live in a miraculous era where very generous dual program guys like Dr. Yassin and even Dr. Picos in Florida. I mean, you know, not all oral surgeons, and I understand it, are probably thrilled with the GPs doing lots of this stuff. But here's the thing. The education is out there like it's never been out there before. And I'm going to tell you, I'm not happy to tell you that when I graduated dental school, University of Pennsylvania, some 40 years ago, I was at best average. I just was. And I got this amazing career because of a lifetime investment in doing what you guys are doing right now. And you can become incredibly proficient. I mean, we all know, don't we? We all have this friend that's a GP that does amazing endodontics, right? I got GPs like that, or does amazing ortho. For me, my journey in the last 20 years of a 40-year career took me in the direction of surgery and implants. And I'm very grateful that we live in, you should be too, that we live in this time that's just amazing for us. If you have a guy like me can become proficient enough to teach others, then you guys listening can certainly accomplish this. So let me get to this for you.
Thank you, Dr. Rasner.
You're quite welcome. So the very first thing, I'm going to lose some of you when I do this on the side. Yeah, no, I'm perfect. So the first thing I want to say to you that you touched on, doctor, is, and this is for you guys, it's management of you and the patient. And this, so when you're doing these kind of procedures, and I've had the privilege of teaching all over the country, even live. I teach live in my office, which is pretty cool. You can come in without a New Jersey license and be allowed to learn these procedures on patients because I have an agreement with the state of New Jersey Board of Dentistry. But I've been in situations where out of my state, where the patients were not sedated. And when I say sedated, I mean either orally sedated or IV sedated. And that changes everything for me. I can give you the most talented surgeon listening in right this second. And the number one thing that will make him average or mediocre is a patient that he does not have control of, that he thinks that he's hurting, that's moving around in the chair. So you cannot underscore the significance of your outcomes by managing the patient, and chime in anytime you want, doctor, by having them sedated. 100% of the time, my patients that are in for extractions or implant-related procedures, and for that matter, to be quite honest with you, a lot of my other procedures as well, they are sedated because it makes me a better doctor, and it'll make you a better doctor. And those of you that might have listened last week, there is my protocol that this was introduced to me by a surgeon 20 some years ago. And a lot of people question me, well, why do you use Atarax and Benadryl? Don't they do the same thing? The truth of the matter is I've had such unbelievable predictability and success with what you're looking at on the screen, is that I wouldn't dare change it. Now, I have to add to you that it's the fourth component of this is nitrous oxide for sure. The truth is Benadryl gives a sedative effect. Atarax actually has an anti-anxiety effect. But this is such a predictable regimen for me that I use this 9-to-1 than I would IV sedation. So it is so worth you getting the permit in whatever state you're listening to. I just don't understand, because I've been professing this for 20 years, why more of my colleagues have not jumped on the bandwagon and got their permit to deliver this. Because I'm going to tell you something. There have been occasions where a patient talked me out of it. Okay, they say, I don't need that. I don't like to take medicine. And those surgeries are not as good as my other surgeries. If I think I'm hurting them, or they're even just moving. You can imagine a lot of these procedures require unbelievable precision, and you can't have people moving around. If you can see the slide on the bottom, is my email. And if you don't have my protocol from last week's presentation, and I don't know if you can see it on the screen, it's simply my name. It's Dr. Dr. Rasner at AOL.com. And I'll send you the oral sedation protocol. So let me move on. Another thing I would tell you to do, and Dr. Yassin, I think, alluded to this too, is develop safe practice habits. These are things that you may not think about in the very, very beginning. But imagine, everything I say to you has probably happened to me, which is why I'm so passionate about it. Imagine you're in a case and you have really controlling the case beautifully. And I don't know, you break off a part of a crown or a tooth and it flies in the back of the throat. It doesn't take but habit and a couple of minutes for you to invest in a number of safe practice skills to block the airway or block them from aspirating something. And I use one of the two you see right now. So you see, I'm going to be decarnating these teeth, taking the crowns down to the gingiva. And a lot of times, even though I don't want it to, the crown flicks off and I'm protected because I have either this outfit, this is called C Sponge 3. I don't care where you get it from. This is not what this lecture is about. I'm just sharing with you what I use. This comes from Sabra Dental Products. And then the other one I use is Airway Armor Medium. And I just go back and forth on whichever one. But be sure, when you get into this, it's easy to overlook this. And you can ruin a perfectly good afternoon by having somebody have a tremendous laryngospasm or even worse, because you didn't take a few seconds to protect yourself. While we're on it, I want to tell you something else. My goal when I teach is to make your life better, not complicated. So this is my general rule of thumb. I'm not kidding. Now, lots of you have heard me speak on practice management, and you've heard my extraordinary success. That is on mainly ASA 1 and 2 patients. Don't feel that you have to do every patient. There's certainly patients that are better served in the environment of an oral surgeon's office, in the environment of a hospital. And so I can stay, and so can you, plenty busy, just simply doing healthy patients or healthy patients that are controlled because of medication. When they're not controlled, I take a really hard look if I want to do that case. So medical management of the patient can be very easy. You see on the slide, it says no thirds. Now, I'll probably get a lot of hate mail for that. But I look at risk and reward. And nobody can argue with me that there's not potential for greater morbidity in the lower third molar and even the upper third molar area. So, and by the way, I want a good relationship with my oral surgeons, and oral surgeons around the United States don't all do implants, just like not all GPs do surgery. So I'm very happy to send out third molars. It's just not worth it to me. I am trained and have performed many, many ramus grafts. I know the anatomy down there. I'm very comfortable with it. It's just not worth it to me to go in and do it. This is my motto. I'm trying to shape you and protect you with one clinician's opinion. And then with children, First of all, I don't sedate children. What's a children? Let's say under 18 in most cases for me. I stay busy without doing that. And it makes my life quite comfortable. Okay. I said earlier, check out my podcast for detail on this stuff, The Lion-Hearted Dentist. So let's talk about this. On the screen, we have two different challenges, do we not? We have the one tooth adjacent to teeth that you don't want to damage for sure. It might be, it could be worse than this. It could be an aesthetic crown and bridge case. We've all had those, right? We put it in 4 years ago. It looked beautiful. The patient comes in and the lateral is broken off at the gum. And we definitely have to remove the tooth, but we do not want to touch the adjacent tooth. So what is the skill set? And that's what I'll share with you. And then the tooth on the right of the screen looks pretty difficult. Big, let's just say a big bruxer, long-rooted teeth, maybe a history of root canal. These are the cases that I'm going to share with you as to what I think is a very predictable approach. So let's take this case. This is the upper right lateral. Dr. Yassin described an atraumatic extraction quite perfectly. I call it this. I say that you leave it with the same walls of bone that were there before you started. So there you look, there's the 5 walls you want to preserve. The 5th wall, of course, is the floor of the socket. So if you get a tooth out and you left those 5 walls, in my world, you did an atraumatic extraction. Because now you can do all kinds of really predictable grafting, or even, as I alluded to when doctor was speaking, you can even do an immediate implant if you have a thick enough biotype in my world and a thick enough buccal plate of bone. And the reason I can say that to you with great authority is because I have many that did not turn out right because I didn't understand those nuances. It looks good the day I did it, and a couple of years later, there's recession. Here's an important slide for you. As we get in and discuss in the next few minutes, we're going to talk about the ways that I graft and who I chose and who I picked it up from. I would tell you that this should be your MO. And the MO is listen to no one, listen to everyone just a little bit. In other words, don't fall in love with one procedure. The way you have to do it is you have to document. I'm sure most of the doctors listening have a camera in your office at this point. So take the extra 3 minutes, photograph before you start. I'm talking about a tooth that you just removed and you're about to graft, and use a protocol because you learned it from someone. What you need to do is learn what works in your hands. So maybe you won't listen to what I tell you to do. Maybe you'll listen to what somebody else you picked up along a different webinar or a live course. It doesn't matter to me. What matters is that your outcomes are predictable to you. So that's a very important part of your success. So here's a quick case. Apologize that you can't really see the whole crowns, but this is after I flapped it, and it's obviously full of pathology and fenestrations, and that's what it looks like. Can you guys see my cursor when I do that? My little, you can't see that?
Yes, we can see it, yes.
Great. So I'm showing you obviously a huge buccal defect. Now I will tell you, there are really respected clinicians, and Dr. Yassin would know this as well, and we all do, that would place immediate implants in this situation. There are people that would do that. And I am of the philosophy that it's 3 months, or at most 16 weeks. Okay, it's 4 months. 4 months in their life, and I can get a result. Most of the time, it's much more predictable. And again, that philosophy, today we have teeth in a day, right? So it's a really hard argument for us to make because I don't do teeth in a day. How do you like that? I got a multi-million-dollar practice and I don't do teeth in a day. And I'm obviously late to the party, but it's just not, I don't see the urgency. And my patients never, ever say to me, not one time I can tell you, why can't I have the teeth in a day tomorrow? It's because they are my patients that have been familiar with me and they trust me, just like yours. So that isn't my approach. And it doesn't mean that I'm right, by the way. It means it's my approach. So what are we using here? And what do we put in a situation like this? And what you're looking at on the screen, there's many approaches to this. The approaches I'm going to give you have worked well for me and kept the decision tree not so complicated. So I'm a big user of BioHorizons Mineros, which is a mineralized graft, allograft. And that's what you're seeing in the holes after I've copiously curetted out the area, irrigated the area. That's fundamental in all your surgeries. There's all kinds of ways. You're looking at PRF there, which, to be clear, and it's beyond the scope of this webinar, that's not going to give you better bone. It's just going to give you better healing and tissue health. And it's great to use in many capacities, and it's not a deal breaker if you don't use it. And there's a way you can sandwich it. You can put a membrane on top of this. So what did I use? Or you can put this as your final layer. So what did I use to get to this? And by the way, you're looking at a time. Remember, we're all going through an evolution. We're evolving. Where I used to close everything with Vicryl. It's just what I used. And probably at the time, it was what the person that taught me was using. Nobody talked about Resilon, a non-resorbable suture, which you see in the literature all the time now, that you see on the lower left of your screen. So I would say to you, you evolve, right? So today, if you saw me use this, if this case was done in my office, I would have certainly closed it with Resilon, a non-resorbable PTFE type of suture that's cleaner. It's harder for it to attract bacteria, despite the fact that the polygalactin Vicryl touts that it's antibacterial. It does tend to track bacteria after a while. So that's why I shifted over the years. I would say to you, I can't recall numerous complications because I use Vicryl. So you have some leeway. And then 16, or not 16 weeks later, months later, you can see I've developed this site for my abutments, and that's the case 4 years into it. Not a perfect case. So let me say this to you at this time, while you can analyze and criticize my central papillae if you want. I would say this to you. Don't beat yourself up to be perfect and try to make every case that you see to be a podium case. You know what a podium case is, right, guys? It's a case that might have gone back to the lab 7 times, so it blows your mind when they show it to you, right? Or maybe you did 3 extra surgeries that you didn't charge the patient for because you knew you wanted to publish the case, or you knew you wanted to show it in an audience. I'm saying to you, I'm not telling you to strive for mediocrity. I'm saying to you, sometimes enough is enough, and it depends on lots of parameters. How about this defect? Now, this is from this year. So this is an 82-year-old doctor that just lost his cuspid. And, you know, sometimes you can exercise every protocol you want on atraumatic extractions. You're going to lose the buccal plate. So, especially in a cuspid. So what do you do with this? Well, let's talk about it. Do you use autogenous bone? You'll never go wrong. I'm talking, when I say what do you do with this, I'm talking about what do you, after you debride the socket, after you irrigate it, now you want to generate regrow bone, what should you put in this? And the answer is, it depends. You know, if it's a 5-wall socket, this is not a 5-wall socket because I lost the buccal wall. If it's a 5-wall socket, in my world, if you use Mineros from BioHorizons or any similar product, you will grow very substantial bone. Now you got to talk about socket seal too. In other words, what do you put on the top of the socket? And that depends on where you're at in the oral cavity. And I'll try to come back to that if time permits. But sometimes you're going to have a combination of graft material. So if autogenous is available, and if you don't mind me adding this, Dr. Yassin, and this is good for me to say to you guys because I started serious surgery about 25 years ago, and I take abundant courses to this day. To this day. I'll tell you something interesting. This past summer in my office, I hosted an oral surgeon who's become quite popular named Frank Zastro. He's from Germany. And Frank is a guy that takes a ramus graft and he splits the ramus and he does these bone plates and gets astonishing horizontal and vertical augmentation. Frank Zastro. Why I'm telling you that is not about that though. In the audience is one of the students was Mike Picos. He was one of the guys. Now Mike Picos wrote a book on bone grafting, but while he's in my audience, he was taking notes like a freshman dental student, like he had never even seen or heard of a bone graft before. I saw him with my own eyes. And so my point is, the learning part of this is forever, okay? So I took a course just in February, right before this horrible thing has happened to all of us. And the course reopened my eyes, believe it or not, to the tuberosity, the maxillary tuberosity, as an amazing source of not only particulate bone, but of bone graft. You can get a bone block graft in a lot of tuberosities. So I'm only saying that to you because the process of deciding what you put in a defect like this is going to change for you depending on what works best for you. And right now, just what I said in the beginning of this presentation is happening to me. I'm going through that process where I'm going in and harvesting bone blocks from the tuberosity with the technique that they recommended. It comes from the work of a guy named Dr. Jose Carlos de Rosa from Brazil, and Brazil, yeah. And I don't know. I can't even tell you if I'm going to think it's a great thing in a year or not, but this is the process. And I want you to be familiar with the process because that's how we get to outstanding outcomes, by trying things, measuring them, and does it work for me? So in this case, do we use Mineros? You could. Nothing wrong with this. Years, that's what I would use. Or do you use a xenograft? And the truth is, so I don't want to confuse you, if you're going to place an implant here, it would be wonderful to have a combination of autogenous, if you can have a site to get it to, and maybe you would go up and open up the tuberosity, and that's a good point too, because another course I took 6 months before this believed in 100% autogenous. They never use any bone in a bottle. And I went back to my office, and you guys can tell that I work in your world when I talk like this. And I said to myself after that course, I'm never using bottle bone again. I'm going to do all autogenous. And guess what happens? You have a hygiene check in room 3 and you run out of time. And the thought of you opening up another intraoral site and harvesting bone doesn't seem as appealing to the bone that's in the bottle right behind you. So the truth is there's room for both. You just have to plan the surgeries and you have to have enough time. That's part of planning. So in this particular case, I used some autogenous that I was able to scrape with a bone scraper from the adjacent bone. And I used Mineros. That's what you're looking at right now. So what kind of membrane did I use? And I'm going to get into the extraction process in a few minutes because it's going to be shockingly easy for you. Me piggybacking off of some of the things Dr. Yassin said. But I wanted to show you how this all comes to fruition. So you can use a cytoplastic metal reinforced membrane over this, which can be complicated to a novice surgeon, somebody that hasn't done a lot of this, because you have to use bone screws. So one way to do it is a non-resorbable cytoplastic membrane that has metal in it to preserve that space. What about collar tape? You can never use collar tape here. It doesn't last long enough. I'm just trying to show you the different principles. How about a titanium membrane? Absolutely, you could use that. Again, requires higher surgical skill set. What did I use? I ended up using Memlock, which I use a lot. It's on the bottom of your screen. That's a cross-linked, long-acting membrane. In other words, it hangs around for like 36 weeks. And you need something to hang around that length of time because that's the process of bone formation in a defect like you're looking at. So not to complicate this, you're looking at a pretty significant defect, were we not? Well, that requires more significant protocols. If this was a 5-wall socket, like most of your extractions, I, as a clinician, would be perfectly content putting minerals or a mineralized allograft, and most of them are the same. They're 50-50 cancellous cortical with bone chips that range from 0.6 millimeters to 1.2. And okay, got that? So what you're looking at there is, that's Memlock. Some guys put Memlock and they don't stabilize it. I did. I stabilize it with a nice system of tacks. You might think I'm doing an advertisement for BioHorizons. It's just who I use. So the tacks come like this on a harpoon type of device. You put it in, you pick it up, and you deliver it into bone. And what do you get 16 weeks later? You get that. So this was at the end of 2019. And actually, I started this in September, I believe. And I'd recently placed the implant. I did use a guide. And we placed 3 implants to do a 4-unit bridge. So let me move on because I'm getting too tied down with grafting. But this is just a same thing that you saw me do in the previous slide. That's a pretty significant lesion, buccal defect, would you not agree? And you could treat that defect with, you would not be wrong to treat it with titanium as your membrane. There's lots of ways to approach this. You could use bone as your graft. You could do a bone graft here. There's a lot of ways to do this. And I used, again, this exact same protocol you saw in the prior slide. And that's with the implant, of course. And there's a tack that was remaining from the previous surgery. So let me get to some things.
Can I just, I just want to comment on this, Dr. Rasner. Great surgeries. It's really important, as you mentioned, we are dealing with anterior mandibular case here. So we are putting like probably 3.0 millimeter of an implant, right?
Yes.
So we don't really need to make things more complicated. You kept it simple. You put like the collagen membrane, you have the bone, and all what you need is probably not more than 6 millimeter of width to place your 3 millimeter implant, 7 millimeter maximum. So we don't really need to go ahead and build more bone, as I always see sometimes right now. People start to try to go with plates or with blocks or whatever complicated surgeries to build more than what we need bone, while you are keeping it simple. Simple is the best way to go. We don't really need to complicate things. So I just wanted to comment on this. It's really hard to grow bone in this case, and you did it greatly and nicely and in the most simple way.
Yeah, and I really appreciate you chiming in. At any time, please. Don't. I can get too talkative, so just jump in at any time. But I want to say to you that he's exactly right, because like I had people, and listen, you could criticize this case as my approach, because you could say what I was told by other clinicians, that well, if you have a buccal defect like I just showed you, so let me take it back like that, they would say it won't preserve the space, that the collagen, remember, that's got to be long lasting cross-linked collagen that'll stick around for a while. They'll say that'll cave into that space. But remember what I said, you have to do what works in your hands. And I got to tell you, it's a lot more complicated as soon as you start involving membranes that you have to remove, membranes that require bone screws like titanium, or like metal reinforced cytoplastic type of membranes. It doesn't mean you shouldn't use them. I'm just saying it's more complicated. Okay, so let me get to this, because this is where I was really supposed to focus on. And exactly, I heard Dr. Yassin say the same thing. I'm going to say it a different way. The very first thing I teach my docs is just slow down for a second and let's strategize as to what we need to do here. What's the bone density look like from the x-ray? What's the root anatomy? Has it had a root? This is before we take a tooth out. Has it had root canal? Are they a bruxer? What's the story on the adjacent teeth? Obviously, in a case where you're taking out multiple teeth, the approach becomes more simplified in many ways, but when you have to take one tooth out and preserve the other two, it's a different ballgame for me. So strategize. It takes you but a minute or two. So like if you look at this, and if we were taking out, number 18, what's the treatment plan, number one? Is there a chance we're going to put an implant on the second molar? What's the bone quality? All these things are going to impact the way I'm going to go after that tooth. So let me just give an example. I'm a very big fan of sectioning teeth. Why? Because it minimizes the stress on the surrounding bone. And that leads to, if I minimize it, it probably means I won't lose the wall. And if I don't lose the wall, it becomes a 5-wall socket, and that's atraumatic. I can do almost anything I want in an atraumatic socket. What if this was conical root, which sometimes we're lucky that they are? That makes the whole thing different to me. I might obviously not going to section that tooth. So let's move on. Do we need to flap? Do we need to use burrs? And what burrs do we need to section? So, good example of what I do with most molars. So let me say what I would do. So I don't have the pre-op here, but I can tell you what I do, Alan, in most of my cases of a molar like this, and I'm going to show this momentarily, is, well, you know what, I'm going to come back to it because I'm actually going to show it, so it'll slow us down. I want to point out that today, and I saw Dr. Yassin do this in his lecture, if you're going to put an implant in a molar, a lot of people are having great success by, after they graft, using a cytoplastic membrane that you see on the lower right of the screen. And I noticed you had that in your last lecture. And that's you remove that in about 4 weeks. It doesn't require anesthetic. You simply, you keep it in with a cross X stitch. And it's a little more complicated than that because you have to take that membrane and have it go down the buccal about 3 millimeters to 4 and down the palate. So you got to make a little pouch, but it works very nicely and gives you a very nice result. In the old days, a lot of times we thought we had to get primary closure to get good results. And this helps you not have to get primary closure. And this is another example of how I use it. There's a great example of me doing it on an upper molar. So that membrane, which has a shiny side and a dull side, the shiny side faces away from you, and you tuck it over the buccal about 4 millimeters and across the palate. Okay. And I keep it in with a cross X stitch. And that's what it looks like in about 4 weeks. It's kind of funky at that point, but underneath you have very nice tissue. Let me say this before I get into the quick ABCs of how we get teeth out. So this patient, I show you her feet first because that's all I can remember about her. As soon as I walked in the room, she wouldn't stop moving her feet. She was thrashing her legs. Very hard to manage. And by the way, she was on my protocol. But we also keep ropinirole in the office, which is a restless leg syndrome drug, and works very quickly and very effectively in calming down. But why am I showing you this? Because I had her teeth out in about 3 minutes. All we did is use molt elevators to sever the fibers. Don't be fooled, not in this case so much, but I'll say any case, on a really loose tooth and just going in and trying to rip it out with a pair of forceps, because that's what you'll do. You'll literally rip it out, and you'll probably take with it at times a bunch of lingual tissue that you'd rather not have done. So let's keep our life simple and take an extra 60 seconds. It almost seems like it's not accomplishing anything, but I will promise you it'll save you from ripping tissue if you make a habit of not using it. And you can do it with a blade on the right or the molt elevators on the left. Either one, go around the tooth circumferentially and sever the fibers. And, you know, it'll look like that when you're done. I did a little frenectomy, which I wasn't quite finished with. We'll talk about that another time. And that's all the instrumentation we really needed. Same with the periodontal patient. So an acronym I want you to understand. ATM. A, always be under control. I don't care if you're on your 2000th extraction. Do I have control on every step? It just becomes habit. Think before you act and be methodical. So let me explain. Always under control. So let me give an example. So there's times, right, where you're running behind and your hygienist comes in and says, oh, I have a hygiene check, you know, and you started the case a little late to begin with, and now you're on the upper palate with an elevator, or you're on the lingual of a tooth with an elevator. And that's how you puncture the floor of the mouth or the palate, because you slip off, because you weren't focused and you weren't under control. That's what I mean. And I'm telling you, it can become a very good habit. No matter how many teeth you take out in a given day, when you put an instrument on a portion of the oral cavity that makes you vulnerable, then you have to focus in even harder. Think before you act. So when you're going to see in a minute, I'm going to encourage you to use surgical burrs, and I create troughs, T-R-O-U-G-H, little troughs on the mesial and distal of my teeth. So then I can then insert an elevator, which is the magic I'm going to give you. I cannot wait till you go back and try this gem I'm about to give you, because it's going to blow your mind on how easy it makes your surgery. But when you're doing the troughing with the surgical burr that I'll share in a moment, you got to think roots are conical, they're not rectangular. So you have to follow the angle of the root, or you'll end up hitting an adjacent root. That makes sense, right? I know this stuff seems obvious, but it's a mistake when you're in the line of duty, when you're in the front lines in the middle of a busy afternoon, you can make such a mistake. So that's what I mean by thinking before you act. And methodical means learning to compartmentalize your case. So what do I mean? Okay, when I go in on that molar I started to explain to you, what do I do? Well, the first thing I do, if it has any metal, I'm going to cut the crown off before I do anything else, if I'm going to section it. Why? Because you don't want to cut the crown off if you ended up flapping a case. You're going to go into cases that you didn't have the intention of flapping, but then you're going to change your mind and you're going to flap it. and now you have a crown, and it's a great way to create metal tattoos in your patient, which they didn't sign on for. So get rid of any metal that may be in your way before the surgery is over. Then I'm going to open the contacts with just an old diamond burr, so I have room to see better. So picture this. Picture a molar that you're about to remove. So if it had a crown, just get rid of the crown first. Open up the mesial and distal contacts. Now you can see good. And if you really want to see better, take it down to the gingival margin, which seems counterintuitive to you because then you won't have anything to grab. I understand. I never really use forceps to take teeth out. I use elevators like most of you do. And I get it so loose with the elevator in a way I'm about to share with you that anything can pop it out at that point. So it's not counterintuitive to cut it down to the gum line. It actually makes you see better. And visibility is the name of the game. So there's a burr you want to know. And remember, here's what you can do if you miss any of this. I gave you my email. I'll give it to you one more time. It's Dr. Rasner, DRRASNER at AOL. And tell me to send you the surgical stuff. It just covers everything. And I have different things I send doctors. And it'll have this Brasler burr on it. I have no agreement with Brasler or any other company for anything I'm showing you. This is what I use. This is a really beautiful thin diamond. And then the other burr I use, and I'm not as in love with this as I used to be, because I feel like they changed the manufacturing protocol. But this is an SS White 1557 SL. And they break off a lot. The diamond will never break off. It'll get bald on you really quick. But this is how I trough, and I'm about to show you. So they're the two burrs. They are all the two burrs I use. One of the two. Real quick talk about, what should you be using for a drill? Well, if you're in some states, like the state of California, it has to be this kind of drill. Because something must have happened in that state, and somebody must have ended up with an air emboli, and it's not mandated in too many states. I don't want to get into this particular lecture whether I think you can use a regular high speed or not. I've done a lot of research on emboli. We all know that they can happen. They're not very common. But when you're using it to trough, especially to create a little channel, that's what a trough is, a channel, on the mesial or the distal of a root that you'll then insert a elevator, there is no soft tissue for you to cause an air emboli. There's tooth there. Now, if you broke off, you got out a couple of the roots on a molar and you use it there, it's a different story. But I've never had an air emboli in the 25 years of doing surgery the way I do. But you wouldn't be wrong to use this, that's for sure. And in California, you have to use it. Okay, this is what I meant about the root. Envision a root. Watch this next slide. That's what roots look like. You can't go straight down or you're going to get in trouble. You have to think when you put the drill in. So here's what I mean by opening contacts. I'm not going to show the whole video, Dr. Tim. Don't worry about it. This is just to give them the idea. So this comes out of just an old diamond pack that I keep my old diamond burrs that are still okay, but I wouldn't want to use them to prep a tooth. That looks easy enough, correct? Well, what did that just do? Well, it stopped me from injuring the adjacent molar, which honestly I've done, which is why I'm doing this. You don't think you're going to do it, then you end up nicking it. And then, as I said, a lot of times, I will then go in with the other diamond, the skinny diamond I showed you a minute ago, and I'll decarnate it. I'll take that crown down to the gingival margin so I can see it crystal clear. And then I'll use, this is the diamond. I'm showing you troughing for just a minute. That's on the upper right part of your screen. Watch what I do. I start out by going on an angle, And this cuts beautifully. It goes bald a lot, so you can't order 3 or 4 of them. You got to have like 20 of them in your office. And as I start to create a channel, I go deeper, and I'll end up doing this on both sides. And it can get a little hairy because, again, I'm right up against that premolar to the right. Sometimes you got to angle things, and I'm going to the depth of the burr. So that's how I use it. Everybody asked, where is that? Let me continue with this. The burr that you just saw, there it is. It's 21 millimeters if you went all the way to the hub. So somebody did a study, I think it was the University of Michigan, on how long teeth are. Again, I can send you this study, but you'll never get in trouble using that burr because there's really no roots virtually with 4,000 some teeth measured that you can get into a danger zone. And to be quite honest with you, even if you went 3/4 of the way, it's rare that you're going to feel the need to go all the way down. Remember why I'm showing you this. This is where you're creating a channel that we're about to put an elevator in. Some basic rules that I know you know. You never take the bone from the osseous, from the buccal or the palate, because that's not going to grow back. But interradicular bone will grow back, and so you're safe there. So this next slide, as I like to say, is the whole enchilada. It's called creep. And I'm going to tell you that you've had this happen to you, you just don't remember it. So creep is what happens when you place torque on a tooth long enough that it impacts the surrounding periodontal ligament and the bone. Do you ever recall a time where you went to pull a tooth, maybe in your first year of practice, maybe on your mother-in-law, and you didn't want to do the case, but you did it anyway, and it was a lower molar, and you were in there for a long, long time, too long, and you gave up. You just took a break. You went to the bathroom or you did a hygiene check, and you came back, and the tooth was looser than when you left. That's creep. That's what it is. So when I see guys at my courses, I see them jerking the forceps or the elevator rapidly left to right with their hand. What you need to do, and it doesn't matter to me, these are old school elevators. I use these for 20 years because it wasn't until about 10 years ago they came up with these new age elevators that Alan was showing that are amazing. But you can do everything I'm telling you with these. And I know some of you are listening today from that work in public health centers. God bless you. And you work for the government and you don't have access to fancy schmancy $1,000 elevator kits. So these work. I'm telling you. But today you have luxators, which I love. And you have a number of companies that sell these micro special angled elevators. It doesn't matter to me whether it's these, although these are a little bit on the thick end. Luxators are these. These are going to go into the channel you created, and then you're going to turn the instrument. This is the whole thing right here. You're going to turn the instrument so that the torque is away from the buccal wall. That's easy to picture, right? You're going to put an elevator into the channel that you created. You're going to exert torque so that the pressure is on the lingual or the palatal, not the buccal, which is enticing for you because it'll come out the buccal very easily along with the buccal wall. And we don't want that. So spend the extra time. Now here's the magic. 10 seconds. I'm not kidding. And it's going to seem like an eternity. So when you put the elevator in the channel, I want you to try this just one time the next time you take a tooth out. So I'm talking about a molar. So let's talk about a molar for a minute. If it was a molar I would do what I told you I did. I would section the tooth. I would take off the crown. And I know to some of you, it sounds like a lot of work. I mean, think about it for a second. That probably takes literally a minute to 2 minutes to decoordinate the tooth. So now you're just looking at a tooth at the level of the gingiva. And if it's a molar, it becomes very easy to section. So you'll section it, you'll hemisect the lower molar. Okay, so now you have two roots, a mesial root and a distal root. So then you'll create a channel by troughing on the mesial of the mesial root, the distal of the mesial root, the mesial of the distal root, and the distal of the distal root. And you'll do that with that diamond. The other burr I showed you is too big. You have to use the diamond. Once you have a channel, you put an elevator in it and you turn and hold away from the buccal for 10 seconds minimum. And some magic's going to happen to you. And I don't listen. The harder the tooth, meaning a bruxer, a person that has big rooted teeth, you must have a well-developed trough or channel. And by the way, before I forget, it's not why I'm telling you this, but I go over every one of these concepts with models at the Seattle AGD in August for 2 days until you can't stand it anymore. But I will tell you that I've had abundant emails over the years of really changing guys' lives, because there's no way that this just works for me. It doesn't just work for me. It's a great protocol if you can become disciplined and be very regimented. That's what I meant by being methodical. What's methodical? I open up context. I take off the crown. I'm talking about a tough molar. Obviously, if it's periodontally compromised, you don't have to go through every step. I'm giving you the hardest scenario. Then you section it. On an upper molar, I would section the mesobuccal from the mesolingual, and then the palatal from the other two. And I would treat each of them as their own root at that point. In other words, picture that in your head right now. You have an upper molar. We've sectioned it. And you might ask me, well, how do you know if you didn't section it the whole way? How do you know this? And Alan, I'll stop in about 3 to 5 minutes and let them ask questions. You ready? So you might say, well, how about if you didn't section the whole tooth? There's a slide I use that says, listen to the tooth and it'll tell you what to do. So listen to me. So you put an elevator in the mesial root on the mesial side and you leverage it toward the distal palatal. If a very good skill for you to feel is the whole root moving, or are you bending the root? You know what I mean? We've all felt that, right? We all get excited when we leverage a tooth and we know we have it. It may be a tooth that really haunted you, but you feel that second. Everybody does. That minute, the whole thing gave a little bit. Well, the same thing applies to the roots of that whole tooth when you section it. And you have to learn that feeling. What happens if you keep forcing and it's not ready to go? You'll break the root. Okay, not the end of the world. You have to have good vision, like Dr. Yassin said. You have to have high-powered magnification and good lighting so that you can see up the socket at that point. And I'll tell you a trick I do. And this is after 25 years of many extractions. If I can't see, I'm going to flap. That's the end of the story. As soon as I flap a tooth, it's a whole nother story. It's like somebody came in with a high beam light, and now the whole thing gets easier for me. So, a couple things. Quick contemplations. This is 3 minutes, and I'm going to stop for questions if that's good.
Okay.
So, what do you do if you get over your head? How will you know if you're overhead? I think if you're on a tooth, one tooth, for maybe 30 minutes or more, you might be over your head. Certainly an hour, you're in trouble. Here's what to do. Stop. Stop. You don't have to take the tooth out that day. The patient will be worse if you keep them in the chair for 2 hours because you think they're going to die if you don't get the tooth out. I'm telling you, particularly if you don't listen to me and you do take a wisdom tooth out and you bark up the wrong wisdom tooth tree and you're in there and you break off the crown and you can't get the roots out, have them bite on gauze, send them to your oral surgeon, be a little embarrassed, be a man or a woman about it. Just, it was harder than I'm used to. I apologize. I think it's best that we make this easier for you at this point. Now, if you get in a habit of doing that more than once in a great while, then take some more courses. That's the truth. It is. But I don't want you to feel that once you start, that if you don't get the tooth out, something dreadful is going to happen to the patient. It's more dreadful if you keep them in the chair for 2 hours. And we've all heard patients who are ruined by dentistry because that happened to them. Okay. If you can't see, flap. Sinus purse, I think it's too much to go over right now.
Correct.
So let me stop there.
Okay. I have a couple of questions, and probably I'm going to share a couple of my thoughts about the extraction, a little bit of my things. So, and also we have a request from Dr. Justin Paulson to share one of his cases with us. Would be great for me and Dr. Rasner to go through it. So let me go ahead and ask you this question. A lot of questions came for the medications for the sedation, right? So a couple of them, the doses, the dosage again, especially for the triazolam, I do believe it's
so it's 0.25 triazolam. Now I want them to know that I don't really follow the DOCS protocol, the docs. Are you familiar with that, Alan?
Yes.
So they give multiple, or at least they used to. Maybe they've changed the protocol. I give the 0.25 triazolam, 50 milligrams Atarax, 25 Benadryl, 90 minutes before the procedure. Okay.
So the second question was like, do you prescribe it beforehand, or do you?
These are great questions. I can only give you my protocol.
Mm-hmm.
I've used it for 24 years, every single day. I do give it to them before the office. I've changed recently. Unless they're an elderly patient, somebody that looks like they don't move around so great, they use a walker, I have them come to the office early. Other than that, they get it and they take it before they come to me. And I have consents that when these guys ask me to send them the stuff, I have the consents, I'll send them, that I've never had an incident. Unless I'm lying to you right now, I've never had one untoward accident. Nobody's tripped on the way in the office, in the hallway, on the way out. Nobody ever had to call 911 for because they were too sedated. It couldn't be, how you always say, if it's too good to be true, it's not true.
Right.
This isn't that. It's too good to be true, and it's true. Right. It doesn't work 100% of the time because it's not going to, some people, depending on the procedure, that patient that's hysterical when you first meet them in the consultation room because they're so fearful of dentistry. I wouldn't waste my time trying to be a hero with this, or a patient that you're going to do third molars on or a ramus graft, that kind of stuff. I would IV sedate them, but 90%, 90. Go ahead.
I agree with you. I personally, I do 90% of my cases under IV sedation. The left 10% probably will do oral sedation. So patients have to be relaxed and before any surgery. Would you please just give me a chance to share my screen for a minute? You need to stop your screen. And I just wanted to...
Sorry.
Okay, I'm gonna show at the bottom with stop sharing, I think.
I'm trying to do it. Hold on. I'm sorry. Jeez. What am I doing wrong here? Hold on, guys.
Oh, it's down in the bottom. It should be.
Um, Jeez, I'm so sorry. Give me a minute.
Oh, no worries.
Zoom. Here we go. Here we go. Stop share. Got it.
Perfect. Thank you. I just wanted to go ahead. I had a lot of questions asking about the courses that we've been doing, the implantology, clinical implantology from A to Z. It's Seattle-based course. In 2020, 2021, we're going to be starting in September for 10 sessions. Starting from very beginner level all the way to the advanced level, we are covering all the topics needed. Good thing in this program that you can register in the full program, 10 modules, or even you can pick and choose one module or a couple of modules that you're interested in. We have great guest speakers. Dr. Rasner will be hopefully with us on the next year. And the good thing that it's heavily clinical and surgery. All these techniques that we've been talking about doing extraction, atraumatic extraction, or some advanced techniques of sinus lifting or full arch cases would be utilized in the course as well. I just wanted to above what Dr. Rasner was talking about on those small tips for doing extraction, I wanted to share this nice case with you. It's tooth number 8, failing, non-restorable. I'm going to extract the tooth. As you can see, 3-dimensional CT scan to evaluate if we are a good case for immediate implant placement. Do we have any risk to fracture the buccal bone? In this case, the tooth, as we talked about, classification is class 1. We have enough bone in the palate. Personally, whenever the case is correct, as a correct case for immediate implant placement, I try to go this route with immediate temporization. But I wanted to share this small, nice machine. It's called the Benex. It's German. It's more mechanical. As you can see, you can apply more pressure on the tooth. The concept of this kit is to engage with the root, with the canal, and then through this engagement, we will apply some mechanical pressure to extract the tooth in one at the axis of the root. So then we will apply no pressure. We most of the time we don't really need to remove a lot of bone. Works really good and single rooted teeth. It's really hard to use it in molars or premolars. As you can see, applying some of the pulling forces through a wire will reflect into doing the extraction with minimum trauma, with not a lot of pressure into the area. So, and then as we discussed and Dr. Rasner did, you can decide if you want to go the route with saving all the walls in the extraction socket, and is it a good case to do an immediate implant placement? Like in this case, it was a good case also in the extraction. Another small technology that I wanted to share with you also, we talked about doing the bone removal, we talked about doing the periotome, or Dr. Rasner shared his tips and tricks for doing the extraction. We have this new technique. It's an old and a new, doing the surgical ultrasonic work, which I've been using for a couple of years right now through the ultrasonic machines. We have this machine. It's the Action Piezotome Cube that will provide really the same effect as you are using the periotome, but it is with vibration. That will allow you to get less trauma, less bone removal, to push all the way inside the PDL space, and then give you more mobility to remove the tooth easily and nicely. So it's mainly it's a periotome, but it is vibrating. And it's going to be removed easily with the ultrasonic technology. It has a lot of good extraction kit. even that this tip, the ninja tip, will help us with cutting the teeth. It's powerful cube, and it's something that we need to know that it does exist. Personally, I use it in the very specific cases, especially when I have ankylosed teeth, when I can need to open more PDL space, less trauma to the area. Some studies, we need more studies to discuss this case, because we don't have enough in the literature to describe what happened with the bone and what happened with the immediate implant placement. So it's promising technique. Personally, I use it in some of the aesthetic area cases, and it's good to be mentioned in an extraction lecture. And finally, and this is something we will be discussing actually in the April 29th session as an immediate implant. It's similar to the extraction. This is the partial extraction therapy, what we call the socket shield technique. We will be discussing in details, me and my friend, Dr. Michi Katafuchi, regarding the immediate implant placement, help everybody to make the decision when to consider or when to avoid doing immediate implant placement. So this is going to be on the 29th. It's part of our extractions. Also, it's important for us to mention this partial extraction therapy and in an extraction lecture. I want to invite Dr. Rasner. Dr. Justin Paulson actually is here with us. He's from Montana. He's a general dentist. He is a full-timer with us at the implantology program, and he wanted to share with us his case. So, Justin, are you ready to share your screen and probably have a discussion, me and Dr. Rasner and you and the group, if they have any questions as well?
Sure, sounds good.
Good. I'm going to stop my screen here.
Okay, let me bring up my presentation here. Let's see if it does what it's supposed to.
Good. Thank you for sharing this case with us. How's it going out there in Montana?
It is nice weather. Super bright and shiny, and not cold or snow or anything. So I'm happy with it.
That's good.
Let's see. So I'm not sure if it's going to show the presentation, or is it showing the presentation viewer thing? Is it showing the actual screen that it needs to be shown?
Well, it's the presentation show like that, but it works. It's fine.
Good.
Okay, is that better?
Yes. Okay.
All right. So this is just discussion about dental implant placement for number 31. My name is Justin Polson. Like Alan said, I live in Montana, and I actually fly in for his course every month. I can't recommend it enough. If you guys are looking for anything to give you clinical experience in placing implants, you really need to look into it. It's the best money I've spent on education yet. So I saw somebody that had a question about where to go for it. It's look at washingtonagd.org and clinical implantology. Just look it up. It's worth it. Anyway, so this is something that we usually do on a monthly basis before the course. We all get together and talk on the phone about certain cases, and you can bring in your own patients. I do all the time. In fact, some of the pictures that you guys saw in Alan's presentation was one of my patients. So this is about a patient of mine just recently, not one that I brought to the course, but it's talking about, can we place an implant in this spot? It's number 31. It has a complication that you'll see here, and how to manage that. But normally we would get together and talk about different cases, and Alan would talk us through some things and then plan for it, and potentially have the patient come and get some treatment done. All right, so this is the CT, or the CBCT of the area. It's site number 31. Even though it looks like it's number 18, it is 31. It's just been switched around. Anyway, so the space right here behind number 30, you can see that you've got 6.77 millimeters of mesodistal space at the ridge. And going down here, we've got a good amount of space on the ridge here. That just looks absolutely beautiful to me whenever I'm looking at placing an implant, just wide football field of bone. It's a little bit shallow there. I mean, it's still got plenty of room to place an implant. I mean, it looks great. Then, so is there enough room for that implant? The answer here is pretty obvious when you look at the tooth behind it. What's the elephant in the room? So with the existing space for the implant placement, it's not really ideal. You could place a 3.5 millimeter diameter implant if you really thread the needle, but you know, for a second molar, a 3.5 millimeter diameter implant is not ideal. So the third molar should be removed, even though Dr. Rasner was just talking about not removing those third molars yourself. So now what we're looking at is how do we deal with that space? How are we going to make space for that implant if you're going to go with a larger diameter? So you're either going to choose between a coronectomy or an extraction. So which one should you do? So looking at this right here, you can kind of see some of the spaces right here where that nerve is. This is probably the worst shot of the bunch. It's a very narrow spot, but still it's got a little bit of a wrap around the portion of the tooth. So to orient you, this is towards the coronal. This is the next cut over here. And then this further down to the apex of the root there. And then as far back before I'm getting more and more of a cone cut from my field of view. So for a coronectomy, the indications should be considered if there are signs that there's a high risk to nerve damage during the extraction. This happens mostly with lower wisdom teeth shown to be close to the inferior alveolar canal radiographically. There's signs of narrowing or diversion of the canal. Roots are darkened and canal is interrupted, interruption of the lamina dura. And you're going to mostly see the lamina dura, especially on the CBCT, of course. And the patient is not medically compromised. They haven't had any sort of radiation to the area. They're not diabetic. They're not immunocompromised. So the tooth has got to be vital. There's not going to be any caries or pathology in the area, and it is non-mobile. It can't be mobile, can't have any bacteria that's going to cause problems because you already have that risk anyway when you're taking that off. So as far as looking at risk levels when you're trying to think of whether you're going to do a coronectomy to get rid of that spot. Low risk, this is going to be when the panoral radiographic appearance turns out on the CBCT scan to be superimposition only. There's a separation of the nerve and the root covering the bone in between. You can see that pretty well right here. You got the nerve right here. You got a nice little bit of amount of bone all the way around. So medium risk, this occurs when the nerve is directly adjacent to the roots of the tooth or it's mildly grooving in the root of the tooth. So this to me looks very familiar from my CBCT from earlier. You don't really have obvious bone in between the tooth and the nerve itself. And it looks like this is a lingual orientation, just kind of like the one that I was showing you. And then the high risk is something that occurs when there is a deep grooving of the tooth by the nerve or even perforation of the tooth root by the nerve with roots growing around the nerve. To me, looking at taking out a third molar, that's terrifying. I don't want to see that. All right, so extraction, that is the other choice here. So what risk for the extraction? You can see, of course, to orient you again, this is the buccal plate on the outside. This is the lingual over here. And you can see that the nerve towards the coronal area of the tooth going back is below the tooth and on the lingual side, and is getting more and more lingual as the tooth goes back. Then looking at the position here, if you're placing forces on the outside right here on the buccal, how's that tooth going to move? You know, you put physical force on this, you're going to have a lever, right? You got buccal force from the buccal, the lingual portion towards the apex is going to move away from that nerve. So you're not really going to compress it if you were to take it out. However, this is a little bit scary right there as it's wrapping around a little bit, but this is, like I said, a very limited portion of that tooth as I was going back. It's just one slice. So right there, you can see a little bit more of the exposure on top. It gives you a better view of what you're going to look at if you were going to flap that back. It didn't have any pathology. There are no caries in the tooth. You could trough right here pretty easily, remove a little bit towards the distal, and then give it some space to roll out. So in order to place something here, you're going to need some space. If you do the coronectomy, it's going to give you some more space here. In my initial image, it showed that if you went all the way back here, that gives you 10 millimeters to place that implant. But because this is more of a moderate risk, you know, you could get that tooth out pretty well and not really have many issues. And then this is, I just wanted to show this. This is exactly what I'd be looking for when I'm looking at a panoramic, is going over the top. Is that line interrupted? Is there something showing that this is getting pushed out of the way? This is looking pretty good for me looking at a panoramic x-ray. However, you saw the CBCT, and that is pretty close to the tooth anyway. So it's just showing the level of risk. But that would be something, like I said, that I would present to Alan as I'm looking at potentially bringing this patient in to place an implant and do either an immediate placement there with a little bit of bone grafting, or just take the tooth out and bone graft and have them come back another time. So anyway, any comments from Dr. Yassin and Dr. Rasner? I know I shot through that pretty quick, but I was just trying to make good time.
No, thank you.
Thank
you for sharing this case. I would.
Oops.
Well, thank you for being so brave and talking about all these details. I know. Guys, I'm so proud of every single doctor in our program, because through the past year, I saw everybody just growing in surgical base and skills, and I'm happy that to see we have some advanced surgical cases like this to be discussed even with our general dentist doctors. I know Dr. Rasner probably will gonna tell you this is too risky for general dentists. Just don't do it. Refer to an oral surgeon, deal with it in a better way. But it's good to have this discussion in our mind for in the group. And you touched base with everything. We discussed the literature. I remember earlier this week. Obviously, you did. You read through this articles that we shared together, and that's amazing. This is the main question: is can we do anything without removing this tooth? We have to do something to this tooth, and the coronectomy is something. Not even every single oral surgeons they believe in the coronectomy. The success rate of the coronectomy is not too high. Taking out some of the teeth and leaving some portion of the roots to be underneath the bone, to be buried underneath the bone, submerged. We have almost around 35 to 40% of infection rate that goes in the coronectomy cases. So we tend to do coronectomy when we have a higher risk. As you said, if we have any, integration between the nerve, the IAN, the bundle, and the tooth. In this case, we have the mandibular nerve. The IAN is located to the lingual of this tooth. In the literature and the coronectomy classification, this is more favorable for extraction. We know for sure that we don't have any. Not going to be having permanent damage to this nerve. So it's going to be, after study, really deep study for the case, going to be we'll be able to remove the tooth, do the implant placement, whether it is simultaneous or stage it into a couple of surgeries. So I agree with you with your treatment plan. I don't know, Steve probably has different point of view. So let's hear from him.
Well, all I'll say is that when I trained with Carl Misch, he used to say, as you're looking at a potential situation, if your gut starts to tell you, then he would go, and no, you don't even finish the sentence. Now, listen, I don't want to come off as a sissy to you guys, and I don't want you to come off as if I don't do any cases that, when I look at this case, first of all, it's a great presentation by you doctor.
Thank you.
Very professional, very done, very nice. To me, I just sense too much, not enough reward for the patient versus the potential risk based on your very good presentation. I don't think I would be doing this one. That's how I feel, you know? And I've done things that I was very surprised it came out so great. You know, maybe it would catch me on a very brave day, and I would probably go for the extraction, not the coronarectomy. But I don't think I think I would punt. You know,
I agree with you on the coronarectomy. I definitely wouldn't do that on my own. That would be one of those things where, like, I don't have the experience in that. I'd send it out. Extraction, I may feel comfortable doing that.
So you're gonna have to remember something, and I don't want to sound litigious, but it's just being real. So if you had to defend yourself for some reason against the Board of Dentistry of Montana or a lawsuit, and they said, well, what if they didn't do this? And you have to think about that. You know, a lot of guys, Carl Misch in particular, I don't think he rarely placed second molar implants to begin with. You know, it's a challenging area on it's challenging area for even a healthy implant to always succeed long term because of the pounds per square inch down there in terms of how much pressure we exert on implants. So there's a lot of ways to look at it. It doesn't matter. What I can tell from watching you do this, you're being trained very well, because that's a beautiful presentation. And I'm not stroking you. That's the way you analyze things. And not everybody does that. So that's an important takeaway for anybody listening. This is a beautiful way to, I mean, we don't have to have a slide presentation for every tooth we do, but the factors you took into account are I'm out, to be blunt. For me, I'm out on this one. And that's because you did a very good job, you know. And, you know, remember this, most of the lawsuits, I mean, may as well talk about it because it's real. Most of the lawsuits are under the first 500 implants and then after the first 5,000. So why is that? Because in the first 500, you don't know what you don't know. And after the first 5,000, you think you're God and nothing will ever fail for you. Okay? So your best, in my opinion, the guys that are the best surgeons, it's nothing wrong with being a little bit vigilant, a little bit afraid. You know, guys that will stop for a minute maybe, even if they have a guided surgery, and take an x-ray of a marker inside, or maybe one of your drills inside the osteotomy that you're creating, if for any reason you suspect something may be wrong, you know what I mean? And in this case that we're talking about right now, my general gut would be to defer. If the bone looks really thin to me on the lingual, I don't know. I don't feel great about it. That's just me though.
It's absolutely, this is the good discussion. The goal is not to do this kind of surgeries, but it's to discuss it, right? And I like the way that Justin is thinking out of the box, trying to even go and study and read literature about even the advanced things, coronarectomy. I know for sure, even here in Seattle, not all the oral surgeons, they believe in advanced cases like coronarectomy. So thank you so much, Justin. I really appreciate the discussion. I agree. This is something, it's really an advanced case, but at least it's good to know this information that you shared with all of us for doing the extraction. There was one comment about doing an ortho extrusion for the third molar. I work closely with my friend, and he's an orthodontist, Dr. Sorabi. He does not really recommend moving the third molar orthodontically. He knows an adult is going to take a long time, but it's absolutely an option. The patients need to understand that they will go through several surgeries to expose the tooth, get some brackets on it, and then we'll spend several months before getting any options. Good. I have a small, quick question for Dr. Rasner here. Uh, would you say that if you place any non-resorbable membrane on top of the graft, you don't need primary closure, or this only possible with a specific cytoplast membrane?
Yeah, the cytoplastic membrane, and by the way, you can get that at lots of places. It's a dense, it's referred to particularly as dense, and it evolved not so long ago. They used to have cytoplastic membranes, but they evolved this dense formula that, yes, you do not have to get primary closure. It is as if you're closing with primary closure. So think about that for a minute. In the area of like an upper molar, and you have a small sinus perf, and there's a protocol for that. Sometimes we don't want to release the flap and come back, and do an apically reposition flap. So it's a very nice way to simplify your surgeries. Yes, you do not have to have primary closure, NO, if you're using that type of membrane.
Right. It's really important to know that this cytoplast membrane is designed with two different surfaces. Against the logic, usually the soft or the smooth surface needs to face the bone, while the rough surface needs to face the soft tissue, the outside of it. So the main goal is to help the epithelium to go all the way underneath the membrane. And this is what Dr. Rasner said. After 3 to 4 weeks, you don't even need any anesthetic to remove this. This membrane is going to pop out really easily. So one probably last question: for full mouth, mostly single extractions, same day under local anesthesia, any particular protocol to control amount of anesthetic and epi? Just try, Dr. Rasner.
I want to make sure I understand the question. Full mouth extraction? What did you say?
Full mouth, mostly simple extractions, full mouth extraction, local anesthetic, any particular protocol to control amount of anesthetic and the epi used.
Yeah.
Probably the doctor, this is coming from Dr. Patel. Yeah.
Yeah, my answer is that in my experience, first of all, I use Septicane, which is Articaine, on my anesthetic, and I would have zero problem with the amount of epinephrine. I don't find it to be a thing. I don't find it to be a difficult challenge to anesthetize a full arch with I don't know how many carpals it takes, but I don't really think that's going to be an issue for you whatsoever, particularly if you're using something as effective as Articaine.
Using the sedation, any kind of sedation, IV or oral sedation, will absolutely help you with control the whole case and make yourself as a surgeon more calm, and then mainly controlling everything. I have another question for you, Dr. Rasner. When creating...
I don't mind. If I was, let's say we were going to do a full mouth upper and they had 6 lowers, 22 through 27, I never anesthetize both arches at once, just a little pearl, because it might get complicated and it may take you longer for whatever reason. And so I don't do opposite arches until I'm done one arch, even though it's a little bit more work for me. Go ahead. I'm sorry, Alan.
No, perfect. No, amazing tip, actually. Let's get a couple of questions. We are Dr. Rasner, when creating trough, how do you avoid cutting too much of the bone or to damage the adjacent tooth?
Okay, so this is a very common question, and I know it sounds foreign to you, and I promise you, I'm not selling a course at Seattle, but you would see all this stuff very, very clearly if you showed up. And look, remember what we're doing right now. All of us, even I'm learning right now as I'm doing a seminar, even though I'm one of the hosts, I'm learning. And we're all in a form of learning. That's what really good dentists, doctors, clinicians do. They never stop. So this isn't the end for you. So if you don't get 100% of this, do not fret. But let me go back and tell you. Remember I said to think before you act. So I'm telling you, I don't know how many teeth I've taken out, but I've used this protocol for many, many years. Even I stop, and maybe I'll push back from the chair a little bit, and I'll look at the angle. Do I have the right angle of my burr to follow the root? That's how I don't nick the adjacent tooth. You nick the adjacent tooth because you lose sight of that for a second, And another way is I decarnate these teeth, so I can see the outline very clearly, and it's very easy for me to follow that root. In terms of not taking too much bone, everybody wants to know, well, where does that burr go? What if you take too much tooth away? Well, that's no problem, except that when you go to elevate the tooth, it might just break on you, the root, instead of the whole tooth moving. After you do a couple of these, you'll get a feel for staying right up. You'll actually feel the diamond, even though it's cutting, up against the root, because they feel different. When a diamond's cutting bone and a diamond's cutting tooth, it's two different feels. I'm telling you, it's a very easy skill to develop, and it's a good skill that you should try to develop, because it seems like a lot of work right now to talk about all this. But I promise you, it's much better for your patient and easier for you than just trying to stick a forceps on the top of the tooth, rotating the forceps left to right, or whatever you were doing that we were taught way back in school. And just picture in your head right now, somebody asked one of these questions. I saw the question. So put a pen in your hand and imagine that the buckle is facing you. So you turn your wrist to the right. That moves the root away from the buckle, and you hold it there for 10 seconds. If you just keep jerking it like real quick little movements, you're going to accomplish nothing. You must exert torque and force, hold 10 seconds, and after a while, this just becomes like so easy and habitual for you that you won't even think it. The teeth are the hardest teeth to take out will become simple for you. I wouldn't make it up. Otherwise, I would be misleading my colleagues, and I don't want to do that. And before the time's out, I know it is, I want to give my email, because I saw questions that some of you would just write to me. It'll be easier for me. It's my name, Dr. Rasner at AOL. I'm sorry, Alan, that's it.
That's fine. No worries. That's great. Thank you so much, Dr. Rasner, for the great presentation, sharing all this tips and tricks and all the spirals. We appreciate it. Looking forward to having you here in Seattle, probably soon. Yeah.
I do want to say for you, and he doesn't know I'm saying this, I promise you. There's many fine programs around the United States to learn implant dentistry. A lot of maxi courses, the Mish Institute. The thing that's unique, that's very hard to find, is the live patient surgeries. I hope you guys understand this. So even some of the best programs in the United States do not have the ability as part of the course unless you go out of the country. I have my own implant surgery course, and I'm touting the Seattle one with Alan's because it's right there for you, where you not only get didactic. With me, you only get to surgery. You have to have been through a program of didactic, but you have both there. And you can't learn this stuff in 2 months. The fact that you've established it over 10 months or a year, whatever you said, is absolutely perfect. And that'll be the beginning for you guys. It'll never stop ending, but you have a real jewel in that program out there. There's not many like it. And I'm proud to be connected to it.
Thank you so much. Thank you so much, Dr. Rasner. We're proud to have you on board with us, and appreciate your comments and compliments. We're gonna be seeing you guys probably in the next Implant Study Club. It's April the 29th. We're gonna be discussing immediate implants, why, when, how, with Dr. Michi Katefuchi. He's a periodontist, my colleague here in Seattle. If you have any questions, you can reach out to Dr. Rasner. He just provided his email address, drrasner@aol.com. Feel free to reach out to me. This is my social media, my email address as well. I'm happy to share with you any of the literature we talked about or any of the tips and tricks we discussed. Thank you so much, everybody, for being with us. Thank you, Dr. Rasner, again. And yeah, and we'll see you, everybody, soon. Thank you, Dr. Hess and the Washington Academy of General Dentistry Group.
Thank you, Dr. Yassin and Rasner. If you'd stop sharing your screen there, I'll share my screen and we'll just bring everybody back up to speed with our upcoming webinars. All righty. And so we'll just let this slideshow run for a couple of minutes here so you can see what's coming up over the next week and a half or so. So that... Okay, thanks again to all our sponsors, Washington Academy of General Dentistry, the Canadian Academy of Restorative Dentistry and Prosthodontics, University of Washington School of Dentistry, CE Department, the Pierce County Dental Society, Snohomish County Dental Society, and Seattle King County Dental Society, Comet USA, and Patterson Dental. We'd like to thank you for your support. Thank you for the support of the Croatian Academy of Aesthetic Dental Medicine today on our webinars. And we look forward to more of the implant study clubs coming up. Those will be featured on our WashingtonAGD.org website here within the next day or so. You can use the QR code to navigate to our website or register for different courses using those QR codes. If you want to see a recording of these webinars, you can see those at YouTube, and it's Washington Academy of General Dentistry. Just type that into the search, hit enter, and then remember to like and subscribe. For young dentists out there, remember August 15th, we're hosting our Crown 101 course again. That's from analog to digital. And thank you to all our sponsors for that one, being Air, Comet USA, and Kettenbach. All righty, tomorrow we start with our webinars again at 9:30. We've got 3 webinars on tap, so please set your alarm clocks or your reminders and get registered, because those reminders, if you register, you'll get reminders automatically sent to your email. For CE credit today for the dental implant study club here with Dr. Yassin and Dr. Rasner, you will receive 2 CE credits. Some of these webinars, we plan on giving out 1 CE credit, but if it changes based on the number of hours that we spend together, we modify those for you and submit that to the Academy of General Dentistry, so you don't need to worry about missing out on credits. Remember, all these webinars are being offered free of charge to you as a membership benefit as an AGD member, but you can invite non-AGD members, and you can invite your staff and spouses and whoever else you want to attend these. With that, I just want to say, from the Washington Academy of General Dentistry, Stay Home, Stay Healthy CE series, thank you, and we look forward to seeing you tomorrow. Thanks, guys.
Thank you so much.
Rasner and Dr. Yassin. Excellent.
Thank you, Dr. Hayamoto. Thank you, Dr. Rasner. It was great. Thanks, Val. You're the
Thank you, guys.
superhero. Okay, we'll talk soon. I'm going to give you a call. Thank you.
Dr.
Bye, guys.
Thank you,
Please
Rockstar.
send
Yes.
me the updated PowerPoint for the information for the 29th.
Yes, Val, can you please send me the link so I can get the QR?
Will do. It's already done.
Perfect. Okay.
Thank
Thank
you.
you.
Thank
Have
you,
a good night.
guys.
Bye-bye.
Bye-bye.